Okay, perfect. Hi, everyone. It's really nice to be here virtually, and it's really nice to see some familiar faces and some new faces as well. So virtual faces, I suppose. I'm going to try and share my screen, and let's see how we were trying this. Okay. Um, okay. So today we're going to talk little bit about youth suicide in Canada in particular, and also think about some of the epidemiology, think about what's happened to kids over the last number of years, and the COVID pandemic. Try and think about some evidence-based suicide prevention interventions for youth in acute care settings. Um, as people here will be aware of, youth suicide, suicide in general, but youth suicide in particular, has really been a very difficult problem to try and solve. So, you may be aware that that suicide is actually the second leading cause of death among youth and young adults, and depending on how you look at the age groups. Sometimes it's third in the younger children, but in older teens, it's the second leading cause of death in Canada. If we look at numbers, absolute numbers over the last number of years, this is compiled data that I've taken from Stats Canada, and we can see here that more youth take their own lives than the top 10 most fatal diseases in childhood combined. So it really is a significant problem, and one that I'm really grateful to Sakina and everyone who has made this a forum to have more conversations and think together collaborations about solving it. And talk a little bit about what youth suicide epidemiology looks like in Canada. And I think when we now, different maybe 5, 6 years ago, but certainly now when we think about it, we have to think about time trends. We also have to think about the pandemic, and think about before and sort of during the pandemic and since pandemic, and in the way that we think about trends with respect to youth suicide in Canada and also globally. So, leading up to the pandemic, this is so data over the last 20 years leading up to the pandemic, we can see here that emergency department visits, hospitalizations, and ICU admissions for suicide attempt, and people here will know that suicide attempt is an important predictor of suicide. You can see that we were actually making some progress. I don't know if you can see my cursor, but we were actually making some progress here up until sort of close to about 2009 or so, to 2010. And then we started to see an increase in both emergency department visits and hospitalizations. This is Ontario data, just to say, kids were coming to the emergency department, started to come more often with a safety-related concern, a suicide attempt in particular, and severity, hospitalizations also increasing along with those rates. And I think one thing that's important for us to understand is the context in which this is occurring. So if we look at rates in the orange here of child and youth emergency department visits for suicide attempt or suicide ideation, this is in orange. Again, we see that increase starting around 2009, 2010. We compare it with all pediatric emergency department visits. So visits for any other indication in the rest of child health, we said that actually was fairly flat. So it's not that kids were coming to the emergency department more often in general. In general, actually, we were doing pretty well at stabilizing those rates, but not so well in mental health, where we see an increase in child and youth visits for suicide attempts and ideation. This is US data, but similar to Canadian data. One thing I think that's important for us to think about is gender differences. And when we think about youth suicide prevention, and we see here on the left side, all youth. And again, this is Ontario, but again, you'll see it's very similar in terms of pattern, where we see this improvement, making some progress, and then some reversal of those trends from 2009. We look at it by gender, and here we have female youth in the open circles on top and male youth in the dark circles, the closed circles on the bottom. We can see that a lot of it, even though some increase in boys as well, really being driven by this increase in self-harm by girls in particular during that time. Now, so girls making more suicide attempts or engaging in self-harm more often than boys. But if we look here at suicide death now among youth, again, this is the Canadian data at the top, but you'll see a lot of very similar patterns in other countries. We'll see that now we have the dark circles as the higher rate and the open circles as the lower rate, showing us that when it comes to suicide death, more boys die by suicide than girls in general, with a little bit of variation in younger children more recently in Canada. But overall, this does tend to be the trend where we see girls make more suicide attempts and engage in more self-harm than boys, and yet more boys die of suicide. And that's sometimes referred to as the gender paradox in youth suicide and youth suicide prevention. So when we think about trends in youth self-harm and suicide before the pandemic, and we see a few things to think about. One is that there was this decrease into 2009 or so, and then an increase. We see that trend has been reflected across the spectrum of severity, coming to the hospital, as well as severity of presentations. We see the importance of gender and thinking about gender when we think about youth suicide prevention. And there's a contrast here between what we're seeing in our area of clinical and practice, as well as clinical research, and what the rest of general pediatric acute health service use looks like. Okay, so that brings us to COVID and what happened with the COVID pandemic. I think there was a lot in the news. There was certainly a lot of social media, a lot of popular press, a lot of research as well, trying to understand, theorizing, looking at different ways of understanding what happened with respect to youth acute mental health during the COVID pandemic. And in Canada, what we saw was a dramatic increase in girls, again, coming to the emergency department with safety-related concerns, self-poisoning, self-harm, suicide ideation, and that's girls of all ages. So younger in the green and older in the red on top, the flatter dashes. Really, some increase in boys as well, but really further increasing girls with the start of the pandemic. We wondered whether this was just something to do with Canada or more globally, and can just see here that this is the case for hospitalizations as well. Again, just a marker of severity. And so we undertook a large literature review and meta-analysis trying to understand this across 18 countries, 42 studies, over 11 million emergency department visits, to try and understand what happened with the onset of the pandemic and really comparing mean changes in visits, the ratio of rates during versus prior to the pandemic. And what we see here is across all countries, we see that there was a 22% increase in attempted suicide during compared with before the pandemic. And this is coming to the emergency department for a suicide attempt. And in comparison, there was a 32% decrease in all other pediatric visits. So again, not a general trend, but something specific to youth and acute mental health, and particularly suicide attempts during the pandemic. And so we also saw that rates were higher in girls and in older adolescents. And so really we were trying to understand, what was driving that, what has been driving that over the last several years. And so it's important to look at, what some of those underlying hypotheses, maybe some of the data that we can try and understand what's going on. One of the things that was going on, of course, is that there were school closures. And this is data from Mandy Newton's group in Alberta, looking at Alberta data in Canada. Um, and they did some really neat analyses where they were able to look at increases in emergency department presentations for safety related problem. During school closures versus school openings. And we're able to show that actually when schools were closed, there was a significant increase in the numbers of kids coming to the emergency department for a suicide attempt or for mental health in general, but particularly for emergency visits related to suicide ideation, suicide attempt, self-harm. And the greatest increase is also observed in, again, older children, high school age children. Um, and so, Alberta is a place that did have school closures like the rest of Canada. Ontario, and particularly the GTA, had the longest school closures of compared with the rest of Canada, and actually some of the longest school closures in the world with respect to COVID. And so this is something that I think we need to think about, is what was going on during, having schools closed. One of the things that was going on is kids weren't able to have in-person activities, obviously, extracurriculars and sports. We did some work that Caitlin LaForge McKenzie in my lab disseminated, finding that, about over half of kids were involved in school sports and extracurriculars before COVID. This number dropped dramatically during COVID. And about half of kids, when we asked them, said that those changes for them were hard or very hard. And when we looked, and I'm not showing this data today, but when we looked to see whether those changes relate to some of their mental health symptoms, depression in particular, we saw significant association with increase in depression with the loss for kids who lost access to their sort of activities, sports, things like that. The other thing that, of course, is probably front of mind for most people is that screen use really increased during that time, partly because kids had to go to school on screens, partly because it was the only way to get together with a friend and socialize, partly because there wasn't much else to do. And so when we looked at the collaboration of cohorts that I have been leading since the COVID pandemic, and when we looked at screen use and specific types of screen use during the COVID pandemic and mental health symptoms in Canada, again, we saw this was also an important factor to think about. We looked at sort of passive watching, we looked at video game use, we looked at e-learning, and we looked at kind of video chatting, socializing. And through these things, we saw that the more time spent on passive forms of screen use like Netflix or that sort of thing, the more time spent in video games, playing video games online, the more time spent in e-learning online. In general, the more screen use in those forums, the greater it was associated with a greater report of depression, anxiety, inattention, and irritability symptoms. Irritability seemed to be more specific to video games. So this is why child report as well as parent report in terms of their screen use, but also their mental health symptoms. And we had hoped that we would find that sort of social interactions online or social like video messaging or social messaging would be the chatting would be protective of some of this. And unfortunately, we didn't see that. So that was disappointing a little bit. What we did look at as well is we looked over time, because some of these associations be cross-sectional over short periods of time, and they're just associations. They're not necessarily talking to us about causation. One of the things that we wanted to understand a bit better was how this played out over time. And, you saw, I showed you Mandy Newton's results around school closures and school openings, and an increase in emergency department visits when schools were closed. Here in our study, we looked across 2 years, and you can see here that the pink columns, the pink shaded columns here are times of school closures. And the green that you see in depression is pre-pandemic. We had some pre-pandemic data about kids' levels of sort of depression symptoms. And so we look here, we split them up into younger children, 8 to 12 years old in blue, older children, 13 to 18 years old in orange. And then the top panel here is depression. The bottom panel here is anxiety. I think you can see that we measured at all of these different time points over those couple of years. You can see here, it's hard to see anything other than kind of a flat line. It's kind of stability of symptoms and an increase from pre-pandemic for children across those 2 years. So that's something that we've tried to think quite a lot about. And really this idea that, for the COVID pandemic, that happened in a series of waves. We saw a series of waves of openings and closings and pandemics. But for children, and youth, that increase in depression and anxiety stayed consistent. So that just helps to give us a little bit of a framework, a little bit of a context, because now we have to think about, okay, so we have this going on. We've had this going on in our society. We've had this problem, and what is happening, or what can we do in the emergency department? And so I'm going to shift a little bit and talk a little bit more about acute care now, sort of as I said I would, and the emergency department in particular. So just to give a little bit of background, about 10 years ago now, there was a really excellent paper published by Yaron Finkelstein at Sick Kids, looking at administrative data, ICAS data, and looking at 20,000 youth, adolescents who presented to the emergency department with a first intentional overdose, and comparing them 20 to 1. So, comparing them to, the 1 million other healthy youth, same age and gender, with no presentation for overdose, and then following them for 10 years data-wise, and seeing that a couple of things. The first important point is that over 99% of the children who came to the emergency department with a first overdose suicide attempt were discharged home at some point. They might have been admitted to hospital, but they were at some point after that able to be discharged home well. And then noticing, though, that if we look at that index attempt, that presentation is associated with an increase in risk of death by suicide. So telling us that, okay, in the moment that they might have been able to go home, but that is a marker of an increased risk that we need to pay attention to, and really concluding that emergency department presentation provides an opportunity for secondary suicide prevention. Secondary because they're kids who have already come with a suicide-related concern, primary being more universal or preventative prevention. Around the same time, in fact, exactly the same year, Kathy Bennett at McMaster in Hamilton was leading a large review of the literature looking at primary prevention in community, as well as some secondary prevention in emergency departments, looking at different programs and their results at that time, also about 10 years ago, and finding after reviewing all of the data that it seemed like the emergency department had sort of had the greatest potential for an effective suicide prevention intervention for children and youth. And so these two kind of lines of evidence together, some very data-based Ontario results, but also a comprehensive review of the literature suggested that, we might need to think about our focus in the emergency department and what we do in the emergency department. But that kind of led us to a gap a bit. So I was someone who was around that time working on the inpatient unit at Sick Kids, working in the, doing emergency consultations as well to the emergency department. Often we would be presented with kids who had suicide ideation, a suicide attempt, and felt that they needed to stay in hospital. And we had this gap in the emergency department and as well on the inpatient unit between their presentation and their treatment. And really, from the perspective of evidence-based care and evidence-informed treatments. I had been a pediatrician before I became a psychiatrist, and I was really used to acute care pediatrics. And so I was used to, other pediatric health conditions and some examples of sepsis, of acute asthma, of diabetic ketoacidosis. These are acute emergencies in pediatrics. And for these emergencies, there's fairly established evidence-informed algorithms, clinical protocols for how to treat these problems in order to have the best outcomes. So whether you come to an emergency department in Toronto, in North Bay, in an academic center, or not, in on a weekend or a weekday in the middle of the night or, 9 a.m., for the most part, people would get very similar care because clinicians in all of these places had evidence-informed algorithms that we were following. This was very different from my experience working in the emergency department and on the unit for kids who present with suicide ideation, suicide attempts. It seemed like there was a lot of variability in treatment, a lot of variability in practice, and that was a result of people doing, the best that they could and feeling that they were doing something that they thought would be helpful, but without the same kind of data, the same kind of consensus around what actually does provide the best outcome. And if you're not familiar with this review that came out last year, it's a really excellent review looking at suicide interventions for youth, sort of the state of the literature. It came out in JAMA Pediatrics. Going through, sort of reviewing different approaches, different treatments, therapies for children and youth who come with suicide attempt or acute suicide ideation, and looking at the body of evidence for each of these treatments, and then the strength of the evidence, trying to understand, what do we know about CBT for this problem in youth, and what is the effectiveness of CBT if we follow kids with respect to their suicide ideation, self-harm, or suicide attempts. And really, I think, disappointing for those of us who do this work, and to see that whether it's sort of acute new interventions or traditional therapies, in general, the strength of our evidence is low, or maybe there's a possibility, there's potential, but we don't really have enough data to feel confident about it. With the exception of perhaps DBT and some DBT informed approaches, but again, very small number overall of trials considering the magnitude of this problem. And so, we have looked at this recently, and when we looked at this kind of 8 to 10 years ago, as well, trying to understand, okay, well, are there elements here from different studies, the studies that have shown effects? Are there elements that or threads that might help us to understand what could be effective, what should we target, and how should we target it? And a couple of the things that came from a few studies, and again, a really small number of studies informing this at the moment in children and youth, it seemed like the things that were important were addressing suicide ideation or suicide risk behaviors directly. So trying to indirectly, let's say, address depression or something related to it didn't seem to be as effective as trying to address suicide directly. It seemed like kids needed sufficient duration. There were a few very brief therapies that were negative, and the couple of interventions that were positive, the trials that were positive, meaning they showed some effect, seemed to be longer. And it was really important to include families and parents to have some effects. And this was some of the studies that had shown some benefit and that we were pulling from at the time. This kind of made sense to us, at least. It certainly made sense to me in the work that I was doing with kids clinically. And it also aligned with some of what we found looking at we did a national surveillance study across Canada looking at near-fatal suicide attempts among adolescents. This is work that Rachel Mitchell, who's at Sunnybrook, and I did. I think Rachel started, I think, when she was training, and now she's established researcher in her own right. It's kind of fun for me in some ways to see how, this data has sort of come through in her own growth. But what we found then is that when we asked ICU units and pediatricians, child psychiatrists who were taking care of these kids in hospitals in acute settings and in very acute settings in ICUs to help us to understand these near fatal suicide attempts, we found some things around, a history of prior attempt was important. A history of self-harm was important. But I think one thing that really stood out to us was that the number one precipitating event that was reported right before that near fatal attempt was a family conflict. It was typically conflict with a parent. And number 2 and 3 were peer conflict and romantic relationship crisis, and they were tied around a third or so. But family conflict was definitely something that we were seeing more commonly for kids who had just come in to the ICU with a suicide attempt. And I think what was really striking for us is that in these cases where parents were at the ICU bedside of their child who had just had a very serious suicide attempt, less than a third of them were aware that their child was even considering suicide. And so that I think was quite sobering, is that, you could have this situation where an attempt could be where parents could feel very shocked that they didn't really know that their child was even thinking about suicide and they were in the ICU with them. This sort of prompted us to look at family conflict a little bit more, and I'll just walk you through this. This is some data from my team, Carly Album, who was a postdoctoral fellow with my lab at the time. And looking at the degree to which youth and parents reported conflict in their relationship with their mother or father, and comparing youth here in the light blue called healthy, but really these are our youth with no psychiatric history and reasonably low symptom scores. In the pink, these are kids who are with depression, major depressive disorder, who are followed for depression in an outpatient clinic. And in the dark blue, These are kids who've come to the emergency department with an acute suicide attempt or self-harm or suicide ideation. And if we compare a healthy, depressed, and suicidal youth with respect to their conflict in the relationships with their parents from both perspectives, we can see that in all of these cases, the youth that are coming to the emergency department with a safety-related problem are reporting higher conflicts with their fathers, with their mothers, compared with depressed or healthy youth. And it's interesting. I think one of the things that has been interesting here, and maybe something we talk about as well, is that that's from the youth perspective. From the parents' perspective, you can see in the far right here, the parents report similar levels of conflict between these are the same children who are coming to the emergency department with a safety-related problem versus depression. So from parents don't see things in the same way as youth in these subgroups, and so that's something that I think for us to think about. But definitely, conflict is something that we need to consider when we think about what is a potentially precipitating or perpetuating factor for youth who come to the emergency department, and what does sort of treatment look like, and how should we think about treatment, and who should we involve when kids are discharged or kids are at home. It's definitely something we were thinking about a lot, and we felt that we needed to develop an intervention. We wanted to try and standardize care. We wanted to try and have a standardized care in the same way that we do for asthma, for sepsis, for other problems, so that people could get the same care no matter where they went. We wanted to try and make that an evidence-informed intervention. And so we started down the road of doing that. This is, gosh, probably about 8 years ago now. And starting out with interviews, starting talk to parents, talking to youth, talking to staff, and trying to understand, the commonalities, the themes, what should be included, what was helpful for kids and families who said they felt better. What were the things that helped them to feel better? What were the things that we addressed, for example? From that, we developed the safety program and a standardized manualized program, drawing from various different modalities depending on what kids were presenting with. So whether it was DBT or family therapy or CBT, trying to pull from these to create a program that was standardized and manualized so that it could be delivered with fidelity, but also flexible enough to be tailored to the individual youth needs. So this is the SAFE program. This is our safety workbook. It's theory-driven. It's individualized. It's modular. It's in 5-6 modules. That's something that we learned from our open pilot when we tested it with children and parents. Was that something that was going to be acceptable? How long should it be? Piloting is really helpful. Kids and parents are very honest when we ask for feedback, and that's really helpful. One of the things that we learned was that the modules were in the wrong order. We needed to move some of the modules around. So, for example, we had our family communication module, I think, as maybe module 5. And we found that that was a really important and really engaging module, but sometimes led to sort of a lot of discussion, and sometimes that in and itself led to some difficulties in communication or conflict. And so we needed to move that module earlier into our intervention so that we had time after that to then address that in subsequent modules, subsequent weeks, rather than sort of have that near the end and then, okay, well, that's the end of this intervention. So that was, these kinds of things. That wasn't the only change that we made based on the youth and parent feedback, but that was sort of one example, really helped us to see what we needed to do and how we need to change it. So then once we had a sort of an intervention that was acceptable to youth and parents, we then took it into a pilot trial. This was a randomized control trial that we had just at Sick Kids. And really, this was to then trial the actual method. So it's one thing to trial the intervention, which we did, and it's another to sort of offer it to people and say, do you want to try this intervention? Totally different, though, to say to people, do you want to enter into a study where we're going to flip a coin and you're either going to get this treatment or you're not? Would you be willing to do that kind of a study? Would you be willing to, if you are randomized to the control arm, if you're randomized to the other sort of not the novel intervention arm, would you stay in the study? Would you stay there so that we can, we need to be able to see what happens in order to be able to know whether our treatment is helpful or not? And so this is really the point of the pilot trial, is to test the study methods and get an idea of recruitment, acceptability into a randomized protocol, and retention. And so that's sort of the foundation for what became the I Am Safe trial. And this is something that we have been running over 4 sites. So kids who came to the emergency department with an acute safety concern were randomized to either the SAFE program, which just sort of explained, or our control arm was something called case navigation. We wanted to still be able to be in touch with people, control for the sort of the non-specific effects of having someone connect with you from the hospital, see how you're doing, see if you need any help, but also help folks navigate and connect with ongoing mental health care. And then we had study outcome assessments at 6 weeks and then at 6 months later. And so these are the 4 sites that we have been running our trial in: Sick Kids, Calgary, Hamilton, McMaster, and Trillium Health Partners, a community site. It was really important for us to have a community site because that's, most children who come to the hospital or emergency department are coming to community hospitals. We randomized 339 children, youth, and families across those 4 sites. Our last study participant just had their last study outcome in December 2025. We're undergoing, like right now, I'd hoped that by now, I'm so optimistic. I hope by now I'd have some preliminary results for you. Unfortunately, still doing the analysis. So I'm hoping that it will come soon. But we've, anxiously awaiting to see the results of our trial. And we'll share those when we'll share those when we have them. I'm going to leave it here because I think it's important that we have a lot of time for questions and conversation. I'm really interested in people's thoughts and experiences themselves. I want to thank all of the people that help with this research, especially across 4 sites. It takes quite a team effort. All the participants for trusting us, and the funders made it possible. I think I'm going to stop there, if that's okay. Is that okay for time?
Yeah.
Sakina?
No, you're
Okay.
great. Thank you so much, Daphne. That
Okay.
was really wonderful. And just reminding people to just share questions in the QA. I know there was a few that were in the chat that I noted down as well. Daphne, I love that your intervention is a point of care in the ED. Do you foresee that coming? It's a bit of a 2-part question. Do you ever see that coming out of the ED into whether it's outpatient clinics, community agencies, and kind of like sharing that intervention? But also, what do you see as kind of the crucial difference in this family therapy for suicide risk than, say, standard family therapy that one might get?
Yeah, okay, so maybe the first, so the impetus for going down this road was really to try and advocate for evidence-based treatments for these kids. And so, I am hopeful that we will show that the intervention is helpful. But, there are many folks who've come before us with excellent ideas, and those trials have been negative, and I'm aware of that. So I am hopeful, but I think we have, from my, perspective, we'll be led by the data to some extent. Um, should the intervention be helpful in decreasing suicide ideation, self-harm, improving family communication, then I think absolutely the idea would be to then try and intervene earlier than the emergency department. And the reason I say this, a couple of reasons. One is because it's surprising maybe to people, maybe not, depending on where you work and your experience. But a lot of youth that do present to the emergency department do so because their therapist told them to. So they have an outpatient therapist and they disclose suicide ideation or self-harm, and the therapist or family physician or pediatrician um, is very concerned and sends them to the emergency department. Ideally, we would like to be able to train folks within the community so that there are some community centers of experience excellence, some community champions where we can provide the treatment, the intervention in the community to sort of decrease the need really to come to the emergency department. So I think that's one that's one piece. This treatment is for kids and families that are very engaged, though I would say not engaged in a necessarily in a help-seeking way, although yes, help-seeking to some extent, but very like they're aware already that there is self-harm. It's a concern for them. They're coming to the emergency department because they're worried about self-harm and suicide ideation. So in the community, that would be the population that um, we would be looking to treat. Kids who really identify, and families together identify that this is something they really do want to work on. So I think those are the sort of the considerations for the community. But hopefully, yes. I think the second part was about the families, right? Your second question was about
Well,
families.
like the parts about because this is a family-based intervention for youth or
Hmm.
suicide risk, which
Hmm.
is great. And just wondering about like the features that you find are like very suicide specific
Mm.
compared to like say standard family therapy.
Yeah. I think that's a really excellent point. So in this intervention, the therapist meets one-to-one with the youth first, without the family. And then after that session, meets together, the same therapist with the youth and the parents ideally together. So it's sort of individual and family combined, which is a bit different than sort of run-of-the-mill family therapy where it's
Mm,
everybody all the time. And the other thing that's different is that, again, it's really focused on communication of acute distress. It's not, it may go down other roads and there may be other things that come up, but the focus here is on the acute distress, communicating it, responding to it in sort of positive, supportive ways. Partly, as I sort of showed some of the data, partly because many parents aren't even aware that their child is even thinking about self-harm or suicide. And partly because when we asked kids in our sort of conversations and treatment, we asked them, have you talked to your parents about this? No, we haven't. Why not? And there could be various reasons for why not.
mhm,
But, your parent in general, parents like they want the best for their kids. They're there to support their kids. They love their children and they desperately want to be helpful. And yet for whatever reason, children are not telling them about
mm,
these thoughts. And so, kids who they're living at home, they're living with parents, they have access to them. They're the adult they have access to the most, typically. we really want to be able to help have those conversations in a way that that support is there and easy to access. So that's
Yeah.
one difference, I think.
Okay. Yeah. Would you be able just to clarify for the audience what acute distress definition you're using? Is it they're coming in with a suicide attempt or
Yeah,
severity of ideation?
it could be as it could be suicide ideation with intent. So, they have really strong thoughts of suicide and they feel like they will act on them, or they're
Mm,
concerned that they are unable to keep from acting on them, or those thoughts are becoming sort of more prevalent. They're harder to distract themselves from. They're feeling less safe.
yeah.
And I
Yeah.
mean, whether
Okay.
there's self-harm accompanying that or not, but they're just generally feeling less able to keep themselves safe and becoming
Right.
more worried about that. Yeah.
Yeah. And for the ED data that you presented, and maybe even for your own study, if you could speak to this, is there data specifically amongst towards LGBTQ plus or racialized communities
Mhm.
within those studies, or is that something that you're looking at within your own study?
Yeah, I mean, it's really, adolescence is a time of identity development, and it would not be uncommon for us to, in the course of the intervention, um, for an issue of gender identity or sexual orientation to emerge within that so that some
Mm,
distress might have been around disclosing that,
mm,
and so helping to facilitate that, or it could be that that's a point of conflict, either within the youth or within the family, so that it's flexible in that way. We don't always know that when they first come to the emergency department, but it wouldn't be uncommon to see that. And certainly kids with, transgender kids with any concerns or any, um, I guess, any thoughts that they think might upset their parents. And sometimes they do, and sometimes they don't. Sometimes it's more about what kids think will upset their parents, than in reality what they find. But these are kids that are at higher risk for sure. We
mm.
did, I might show you actually, can I share a slide one more time?
Yeah, sure.
Okay, so I might just show you uh, here. We did, can you see the thank you slide now?
Yeah.
Okay, so, okay, we did have a look at gender identity. And one of the things we found actually, this is sort of pre-pandemic in the green, and during the pandemic in the orange, and this is data we published, in, you can see the reference just below. We saw a real change in what kids were reporting with respect to their gender identity during the pandemic. And so
Mm,
that's something that I think, when we think about gender identity in general, we also have to think about reporting of it. So there's sort of how do you feel, and then what do you say, right? When you're when you're being asked, or when you're in the emergency department, or so on. And we did see this really big increase in gender diverse youth during pandemic, kids coming during the pandemic, and be interested to hear if people have thoughts about what that's about. Particularly, it looked like the cisgender female group, we saw the proportions change more than the cisgender male group from sort
mm,
of pre to during pandemic. So I'll just stop
mm.
there, but I think it's definitely a relevant, important point.
Yeah. I mean, I wonder if that's also related to the social supports that they maybe had access to. Maybe there's certain things that just became more live for them during the
Mhm.
pandemic because of that, or increased in intensity. Did you include any like ethnicity or race in your data, your demographics, or anything like that?
Yeah, we have, and we are, we haven't analyzed it as well. Like, we're still kind of going through it. The different sites were quite different with respect
Mm,
to diversity. So, Trillium, which is Mississauga, Peel region, very different from Calgary, very different from McMaster. And so I think it's something that we're going to have to think about is both site as well
Yeah.
as race or ethnicity,
Yeah.
for sure.
Yeah. Do you think that also, when you're thinking about stressors that kids that might be coming in um, with respect to their acute distress to the ED, is there any other sense around like the context of what those stressors maybe were? I think maybe with the parents, like, or was it just general conflict, or did it tend to kind of were there any themes maybe that you noticed even anecdotally?
I mean, there are a few that are fairly common, I would say, but they do change. Like they are, individual, to some extent.
Yeah.
Um, but certainly, the self-harm itself can be a source of conflict,
Mm,
which is, one issue. Um, it's not uncommon that there's another mental health problem or substance use problem that's happening,
mhm,
and there's conflict around that. So it might be conflict around cannabis use or vaping, or these are things that are more common even than alcohol use now in youth. And so there may be conflict around um, mental health care and
mm,
how things are kind of playing out in the family. There also not uncommonly conflict around school. School is a huge source of conflict, and it may be
yeah.
around attendance in school or performance in school. Um, Not really understanding what the problem is, why aren't we doing well in school? Why aren't we going every day? And sort of what you see might not be what I see. Social media, I think that is an area of significant conflict. Amount of screen use, what are kids accessing, where are they getting supports, and what does that support look like? What are their peers telling them to do, and how does that align or not with the family values and
Mhm.
the family system? And so I would say those are probably the most common
Yeah.
things that come up.
Okay. What about like neurodivergence? Did that
Mhm.
show up in your research as
Mhm.
well?
Mhm. So from our work on the inpatient unit and with sort of in our pilot work, sort of found that there needed to be there needed to be some degree of I guess insight as well as connection, social connection, but also like some some degree of family connection in order to benefit. So we did not include kids with sort of moderate to severe ASD. Kids who had mild ASD were included in the trial. And so I guess we'll have to look at
Yeah.
that. But I think it's an important point. Like when we have kids with moderate
Mm,
to severe ASD, it may be that this is not there may be other treatments, but this may not be the right treatment.
right. Yeah. Um, so I know that this took place around the pandemic.
Mhm.
That was kind of a big impetus as well. Um, I mean, there was a huge trauma that the world went through, right? And especially, I think that people maybe underestimate the impact of that on kids and the level of just general fear that was like
Yeah.
infused in the air when you stepped outside, you know what I mean? And how that scary that is for kids and the impacts that can have. Um, do you think, and I know that you saw increase in other studies as well, saw these increases in ED presentations. Since the pandemic has waned, has that kind of come back down, or do you see there's any persisting effects in youth that we need to be mindful of in terms of things that maybe have shifted?
Yeah, I think that's a really good question, Sakina. It's probably one of the most important questions, to be honest. And um, as you know, we are always behind
Mm,
in data. And so, we have like data from that are now a couple of years old or a year or two. We're always a little bit behind in our in our data
Mm,
collection, and especially at a population or epidemiological level, which is kind of where we would want that to be.
mm,
But I think that that is the key question. We have to follow. We over our 2 years, as I showed, we didn't see any fluctuation. It seemed like that just once it was high, it has stayed high. I would
mm,
hope that we are going to see some, return to baseline if we haven't seen some return to baseline, but it's definitely something I think we need to be vigilant about. There are other things, as you know, that have come up since then that
mm.
are causing youth distress
Yeah.
now, like in the world, right? War,
Yeah.
but also youth unemployment. There are many things that are stressful, not just for kids, but also for families. And one of the
Mm,
things that we know is really important is parent mental health, because we have seen, and I didn't show the data today, but when parents are not doing well, then children are not doing well. And conversely, we saw bidirectional effects there. When children were not doing well, parents were not doing well. So, they're very interrelated. And I think one of the key kind of takeaways from some of the COVID related work is, we have to think about how to help parents and kids um, at least co-locate some of those services, because right now they're kind of running all over the place to try and get service.
yeah, yeah. I know someone in the chat had also mentioned that doing couples therapy would be, and as a couples therapist, I totally understand that. Like, it's like we're just trying to teach you how to co-parent. You know what
Yeah.
I mean? That in and of itself is such a huge thing.
Yeah, absolutely. And we have like a
Yeah.
lot of kids who are not living with both parents, right? So they're living here,
Mm,
living there, and different rules or different new blended families, or um, that I think that is key. And we really try, if at all possible, to get
yeah.
everyone to do the intervention together. But
Yeah.
um, yeah, that's another huge piece we didn't even get to touch on.
Okay, yeah. I know that there was someone who was asking if there is a manual for your intervention, if that's available online, for someone who's a mental health and addictions worker.
Yeah. So I've had this question a few times, and I completely understand where it's coming from. And what we have sort of agreed that we would do is, if the intervention is effective, then we will gladly make it available. But just my own concerns about evidence-informed care in general in the population, for this population, I just we're going to wait to see what the results are. And if we see that it's helpful, we definitely will make it available.
Yeah, sure. Um, do you have time for a couple of quick questions, Daphne?
Sure. Yeah, sure.
Yeah, I don't know if you have time wise, but there's one more question around like how you might ensure ethical consideration for those participants in the control group.
Oh, sorry. I think you cut out just for a second there. I missed it.
It was about how would you in your study they're doing the RCT, so how might you ensure ethical consideration for the ones in the control group?
Oh, okay. So we talked about this a lot, and you can imagine our research ethics board and all the research ethic boards talked about this a lot. And so everyone gets treatment as usual, right? I mean, the problem is treatment as usual varies so much. Some of our sites really been as usual over the course of the study, which is going to be a problem for me in general, but never mind. Um, and so we have seen a lot of shifts in treatment as usual that everyone had access to. So participating in the study gave them something over and above that. And so it could be that they had a case navigator that they would see weekly, or call at least weekly, until they were connected to aftercare, or it could be the intervention, but everyone was getting something above and beyond what they would have otherwise received had they come to the hospital and not participated in the study.
Right. Okay. I think just as a final question as we wrap up, youth are existing in such a different world than what we grew up in. It's the cultural divide, I think, is so vast. You can't even go back to remember when I was your age because it's completely different context, like in so many different ways. So just as a child psychiatrist, like what do you think that we might need to do as adults, as parents, guardians, extended family to help support youth or find more compassion for what that experience is like? Like what would that advice be for them?
Yeah, it's interesting, especially in this current climate of potentially social media bans for kids 16 and under, this school cell phone free school movement that's really growing. And, I think parents are really trying to manage the social media and like being exposed to things that kids may not be ready for, or developmentally ready for, and trying to be a bit more present. I think feeling like their kids are existing in a parallel universe that they're not present in, and
Mhm.
it's really hard to have a relationship and support someone in something where you have no idea what they're actually going through because it's all hidden from you. And so
Yeah.
all of that, I think, is one piece. I
Yeah.
mean, in general, I would say try just in similarly as we do for kids with it, or for anyone with like addiction problem, for example, as parents, the general um, I would say general advice is prioritize the person, prioritize the relationship over the problem. So
Mm,
whatever the problem is that you're arguing about, just try and prioritize the relationship. Go back to, um, you know, what's going on in the relationship, improving the relationship, and make that a priority over the school attendance, over the grades, over the substance use. To start with, I would say that
yeah.
that's I like in terms of an overarching
Yeah.
advice that I think that tends to stand most parents in good stead.
Yeah. Great. Thank you so much, Daphne. This has been absolutely fabulous. And thank you so much for taking the time. I'm seeing a lot of thank yous in the chat for the wonderful presentation and the insight that you provided. And just letting everyone know that next Monday we are going to stay on this topic of youth, but Dr. Maisha Price is going to specifically talk about LGBTQ plus youth suicide prevention as well. And hope to see you all there. And thank you so much again, Daphne.
Thank you so much. And thanks for everyone for the questions and engagement. And it's really such a pleasure to talk to such an
Yeah,
informed audience. Thank you again. Thank you,
great. Thanks,
Sakina.
Daphne. Take care, everybody. Bye.
Bye bye.